Recording in progress. Good evening, everybody. It's 7 o'clock on Tuesday night. You know what that means? First Tuesday of the month, CSOMA community time. So this is our time to do online webinars and discussions and town halls and legislative updates, and basically to come together as a community on Tuesday nights for a couple hours to sit together and deepen our understanding of this medicine and our ability to share it with our patients. So hi, everyone. Welcome. I'm Ra Adcock. I am the Executive Director of CSOMA. I am joined by two amazing people. I think to this side is Kim Newman,
Hello.
marketing. Hi, Kim. Sorry, Kim, I didn't mean to cut you off.
Nice to see you. Is everybody able to chat? I just put in a question in the chat. This is something that comes up. You wouldn't be able to tell me if you can't chat. So I think I have it working.
Yay. All right, people.
Okay, cool. Lauren, you're
So,
leading.
yeah,
Great.
where are you practicing? Share, let's share. We're a community here. Like, where are you logging in from? Where do you practice? Are you a student? Are you a clinician? Let's just share and get everybody excited about all the different ways we're using this gorgeous medicine. And then, who I'll be introducing even more in a minute, is Anne-Marie Trioni. We're so excited to have Anne-Marie here tonight. She's going to be sharing deep wisdom with us. Okay, a couple things, you guys. So I kind of already promoted every Tuesday night, first Tuesday of the month, pretty much, I think, we are, CSOMA is hosting a webinar series. And I'm going to just quickly screen share and show you guys, for you visual learners out there. You can go to CSOMA's website. Kim, maybe you can put this in the chat, csomaonline.org. This is from our website. If you land at CSOMA, here's what the landing page looks like. Look, this was our lobby day last April, where we lobbied hard to keep benefits for acupuncture in Medi-Cal, successfully lobbied for the second year for that. So here was just part of your team that lobbied on behalf of this medicine. If you go to this top bar here, this pink bar, it shows you all these amazing webinars that we are offering. Now, we believe in an abundance mentality, so we make the webinars free for all, but if you do need credit, then we ask you to make a contribution to CSOMA. If you're a member, it's even less expensive because membership pays for itself in CSOMA. So you can go scroll down and let me just load the older events in case y'all missed out on what we did in September and October. But we had a great webinar in September on blood work and labs. We had a beautiful talk in October with Dennis Von Elg about cardiology and the three treasures. It was such a great discussion that night. Tonight we have Anne-Marie, and she's going to get into all this in a minute. On December 2nd, we have the amazing Jenny Needers, who will be joining us about dry needling, myofascial pain. Jenny is just such a gem also. And then just 2 weeks after that, December 2nd event, we will have our annual review and our legislative town hall, our update, basically what happened in 2025, what's in store 2026 with CSOMA, the California acupuncture profession, all of our events, and our lobbying and legislative work. So go to csomaonline.org. We also have an amazing Instagram page that's happening now. Don't miss us on Instagram. We have Emily doing Instagram for CSOMA. She's incredible. She's so fun. We're all learning from her, so much so that we think Emily's going to be presenting in the 2026 webinar series. Why is that? Because this has been such a success that we are going to continue this Tuesday night, first Tuesday night of the month tradition, and you will have a monthly lineup of free or low cost, if you need credit, webinars all through the 2026 season on all different topics, from how to file taxes to clinical service, more ethics classes and malpractice. So all kinds of different topics, esoteric acupuncture. We're so excited. Fasting, the benefits of fasting and GI health. We're planning our webinars for you right now. In addition to those 12 monthly Tuesday night first Tuesday night, 7 to 9. Tonight's going 7 to 9:30, but in 2026, it's going to go a little shorter. In addition to those monthly webinars, we're going to host 2 live events. So for you SoCal folks, we're going to be at Yosan University on Friday and Saturday, May 1st and 2nd. And for you NorCal, Central Cal folks, we're going to be in Oakland on September 26, 27 or 27, 28. It's going to be Thursday, Friday for that one. So plenty of time to get it on your calendar. But just know that as fun as these Tuesday nights are, and we're having a blast and getting a great turnout, the live events are also incredibly fun to eat together, drink tea together, get our hands on each other, play with seeds and herbs and all the vendors. So we do hope you will also come out for our live events. Okay, that's just a quick update from me, Executive Director of CSOMA. I want to thank our amazing board. Our president is here. I believe Julie is in the crowd. And I want to just thank all of the board members that make CSOMA possible. Kim Newman and I run a lot of the back stuff, and our board members are the ones that are out there doing so much of the work. So we just want to thank the amazing board from CSOMA. Okay, Kim, did I forget anything? Okay, check your emails for this event. If you do need credit, all the information about how to take your credit for this event is in that email. You can always email us at info@csomaonline.org if you have any questions. And with that, I think I'm going to hand it over to you. So we're so excited to welcome back Anne-Marie Trioni. Anne-Marie is a licensed acupuncturist, a California licensed acupuncturist, and a really important person at MIEC, which is one of our main malpractice carriers, and just a really innovative company, really different from any of the other malpractice carriers out there in how their corporate structure is, the deep resources and knowledge that they want to share with us to improve our practices. So Anne-Marie's going to have 2 hats tonight. Her first hat she's going to put on is going to be just talking for a minute or two about MIEC. And then she's going to take that hat off, put on another hat, and teach us tonight. So Anne-Marie, I'm going to turn it over to you. And thanks for being here. Oh, you're on mute. So I'll have you on mute. And I'm going to mute myself and give it to you.
Right.
Okay.
Thank you, Ra. Thank you, Kim. It's a real delight to be with everyone again. I see a lot of names in the chat that I recognize, people that I've seen at other conferences or that I know personally. And so it's good to see all of you and meet the rest of you that I have not met before. So like Ross said, I'm going to wear 2 different hats. I'm going to get started with giving you some information about MIEC, what my role is there, what I do, and how I can bring information, quality value to you and the profession, and then we'll get into the presentation. So let me show you. There we go. And then I'm going to do the presentation. Is that working?
All right. Yeah. Perfect. And we're not seeing your title slide. We're seeing what I think is your second. I'm not sure if you want to the title slide.
There we go. Hold on.
And then
okay.
go. There we go. Now we're on your title slide. It's sharing beautifully. And
all right. Perfect.
And I'm right here for any help. By the way, just one more thing. So you can put questions in the chat since the chat is working. You can also put questions in the Q&A, and we'll either address your questions in the moment or at a question period. Having attended Anne-Marie's talks before, I know that she almost always answers my questions if I'm just patient. So but do ask your questions, and those are 2 places that you can do it. So all right, Anne-Marie, back to you.
All right. So before I get into anything else, I want to take a moment and let you, if you're on your, to go ahead and go to the website to download the presentation. So we keep all of our presentation materials on a website for MIEC, so you can access it at any time. There's a lot that's in there, so just download the PowerPoint deck if you want to follow along, or download it afterwards. And if you need that website after I change it, then go ahead and put that in the chat, and Kim or Rob will give it to you.
Hey, Anne-Marie, I hate to interrupt you one more time. I swear I'm going to zip it after this. We also wanted to mention, thanks to the generosity of MIEC, that one lucky attendee tonight will be winning a $100 Visa gift card. So yeah, so thank you, MIEC. Woo, way to turn a webinar into a party. So we're gonna go till 9:30 tonight. We're gonna have some breaks. We need you to stay through it, and then everyone's name's gonna get put into the giveaway. One person will be contacted tomorrow with an update about the prize. So just thanks for being here. And all right, that's it. That's the last announcement.
That's all right. All right. So as Ross said, my name is Anne Marie Trioni, and I'm the account manager for acupuncturists at MIEC. We're a medical malpractice insurance company based in Oakland. I joined the company 3 years ago this week, actually. I've been a licensed acupuncturist since 2010. So I was in clinic for 12 years, and then I ended up working for MIEC. And so I've kind of gotten to see both sides of the profession. And one of my goals in this position is to really bring everything that I'm learning behind the scenes at the company to the profession, right? What can I do to help you guys reduce your claims or eliminate claims, right? Help create a safety environment for your patients, as well as get CEUs for as well. So, and I do have my insurance license from the state. So that allows me to be able to talk insurance speak and talk acupuncture speak. So if you ever call me, then I can talk both sides and guide you through any confusing topics, and explain what everything means as far as coverages go. All right, so who is MIEC? It stands for Medical Insurance Exchange of California. It was founded in 1975 during the depths of the malpractice crisis. So similar to now, where there are insurance companies that are leaving the state due to homeowners insurance, cost of fires, etc. Back in the 70s, there was a similar crisis, but it had to do with medical malpractice claims. So a group of physicians got together and decided to create a company to insure themselves, and it grew over time. So we just celebrated our 50th anniversary this year, and then they added acupuncturists. Well, let me back up. So they have been insuring physicians, whether it's solo practitioners, groups, or facilities, since 1975. Then they added acupuncture coverage 25 years ago. The company is headquartered in Oakland. And as Ross said, one thing that makes us unique than all the other carriers that are out there is that MIEC is a mutual company, which means we're owned by our members. We're not owned by shareholders. We're not owned by private equity. This means that we exist to take care of our members. We have a not-for-profit philosophy. So we are just trying to collect enough premium to cover expenses and claims. And if there is an excess at the end of the year, an excess of revenue at the end of the year, then we often give dividends back to our members. And I can tell you from working inside the company for the last 3 years that they really walk the talk. So from the president down, everybody really does think about every day, what do our members need? How can we serve them? Which is not always the case with what you think about with insurance companies. I like to think of it as insurance with a heart. We do have more than 1,500 acupuncturists that we insure. Historically, we have been in 4 states: California, Idaho, Alaska, and Hawaii. However, a month ago, we launched a new policy. And as part of that is we are expanding to 12 more states. So I will get on the website here in a moment to guide you through what that looks like. But what's really amazing about this policy is that we've made it more comprehensive, and we've streamlined it, and we've brought the cost down. So it offers now part-time rates, full-time rates, and it's a claims made with a prepaid tail. I know that language may sound a little bit odd, but it basically is going to act like an occurrence policy. So while you have the policy and you ever need to cancel, as you leave, MIEC will continue to be responsible for any claims that happened during the time you had that had the policy. You do not have to buy tail coverage. We are also offering prior acts coverage, premises, additional insured, and entity coverage at no extra charge. There are a few additional add-on coverages that you can add if you want. So let me take you to the website. Make sure I can do this correctly. Ra, you may have to help me. All right, stop the share.
Looking good. And then just find that, go back and you can share,
Yeah, share again.
or again, and then pick your web
There
browser.
we go. All right, do you see it? Website?
Bam, you got it.
Yes?
Perfect.
Okay, great. All right, so here's the new website. We just launched this in the last month. So obviously on your own time, you can go check this out. You can also get a quote online now. You can get a quote and apply for a policy online. So you would just enter your zip code. Here's the page on coverages. So all the states that are in green are states either where that we're going to expand to. So the dark green is where we've been approved so far. The light green are the ones where we're waiting for approval any day. So check that out when you get a chance. Explains what the exclusions are on the policy. The policy is what's considered an open policy with just a few exclusions. So we cover everything in the scope of practice based on the California Acupuncture Board with just a few exclusions. So I don't want to spend too much more time on that, but check it out when you get a chance. All right, so now let me go back to make sure I'm doing this right.
Looking great. And then you can just start your slideshow and we're in.
There we go. All right, it worked. Okay. All right, so here's how we're going to go through this today. So I'm going to go through a foundation of what insurance is and claims. We're going to go over some case studies. We're going to talk about risk management, and we're going to address the law and ethics related to risk management. Questions and comments are encouraged. So as Ross said, post them in the chat. You can also put them in the Q&A. And I plan to pause at certain points to give people an opportunity to go through those questions. Ra's going to jump in if there is a question that is pertinent to what I'm talking about right then and there. We will also have time at the end to go through a longer Q&A and discussion. What I really ask is that please participate. So this kind of topic is much more enjoyable and engaging when we all participate, ask questions, and have a discussion. I don't want to just throw a bunch of information at you. Like, I want to make it interactive. And I know that sometimes talking about claims can be a little bit uncomfortable, especially if you've had a situation. You may not want to share it with everyone, whether it became a claim or not. But I do encourage you to share it in some way. You don't have to say that it happened to you. You can, just make it more in general, because there are things that we can learn from each other that, when you're in clinic by yourself and something happens, you usually don't tell other people, but then we can't learn from it. So as I said, I encourage you to ask questions and participate in the conversation. All right, so learning objectives. We're going to talk about common pitfalls that are seen in medical malpractice claims, how small deviations from standard of care can increase liability exposure, how communication, documentation, and clinic procedures influence the outcome of claims. What are some practical risk reduction strategies that you can use, and what are legal and ethical considerations related to risk management? All right. So why should we have insurance? Well, patients can sue for any reason, whether it's legitimate or not. It's mainly when they feel like they have been harmed. And your professional liability insurance carrier is there to assume the financial risks from you practicing medicine. So injuries, accidents, and adverse reactions happen despite the best of intentions. It is the nature of medical malpractice. And what I'm trying to get at here is that I have a lot of practitioners will tell me, I've never had a claim. And that's great. And there is a low prevalence of claims in our profession. But as a medical insurance company, we know that mistakes happen. We insure a lot of physicians. They're actually more used to, they expect to have a claim at some point in their career. Acupuncturists don't. But the point I'm trying to make is that we know it's a reality of practicing medicine, that accidents happen. Some may just be an accident that does not progress to a claim, and some of them do become claims. So we want to make sure that we get this out in the open and talk about this so we're all aware of what's going on and what your risk exposure is. So insurance is a risk transfer mechanism. So it's taking the burden of you having to pay for a lawyer or pay any damages, and your insurance carrier is taking that on. Coverages usually are broken down in a couple ways. One is legal expenses, so the cost of hiring an attorney to guide you through the entire process, and there's indemnity payouts. So that is the judgment that's against you. So a claim could have, at the end of the day, after a claim is over, it may just involve the legal defense costs, and there may not be a judgment, or there may be a judgment as well. So depending on the claim itself, every claim is different, but insurance, the carrier will cover both of those for you. And one thing to consider when you're looking at your own policy is to look at whether the limits of liability on your policy includes legal expense coverage or not. What I mean is, it's standard to have like 1 million, 3 million coverage limits, 1 million per incident, 3 million aggregate for the year. Some policies, the 1 million, 3 million is what is, let me back up. The legal defense costs are sometimes embedded within that 1 million, 3 million limits, and sometimes it's not. So for example, at MIEC, you have unlimited defense costs. So if it takes a year and $100,000 for, to defend you, then that is a separate bucket that doesn't count against your limits. If there's ever an award, then that 1 million, 3 million is what limits come in to pay for the damages. So not every policy works like that. So it's important for you to read your own policy and to find out whether the legal expenses are included or not in your coverage limits. All right, so as I said before, a patient can sue for any reason, but just because they sue doesn't mean that it's legitimate. It doesn't mean that it's going to progress to a claim. For it to be a malpractice claim, there are 4 elements that must be proven. So the first is that there has to be proof that there was a patient-provider relationship established, and that the provider agreed to accept responsibility for providing the care. Number 2, there's a breach of duty. So the provider failed to adhere or deviated from the standard of care based on expert testimony. So a standard of care is the level of care that a qualified, careful physician would do under the same or similar circumstances. So it's basically saying, was there negligence involved based on the standard of care? Number 3, is there a causal relationship? Is the provider's negligence, breach of duty, was it a substantial factor in causing injury or increasing the risk of harm? Or was it a result of inaction? Number 4, there's an existence of damages. The patient suffered measurable harm as a result of the treatment. That may be physical, emotional, financial, etc. It may be there are new symptoms or old symptoms are aggravated or worsened. So all 4 of those have to be proven in order for it to proceed as a malpractice claim. The other thing that can happen is that you may be investigated by the California Acupuncture Board or for a HIPAA violation. So these are called administrative defense coverage. So again, anyone, actually not just a patient, anyone can complain to the board for any reason. And the board has a duty to investigate all complaints. If there is a criminal element to this, they will refer to the Attorney General for a criminal prosecution. And discipline can range from a fine, suspension, or revocation of a license. There is also dismissal if there's no findings that anything was wrong. And if this happens, it's public. It's available to the public that any disciplinary actions that are taken against someone is on the California Acupuncture Board website, as well as details and all the governmental filings based on hearings or court appearances, etc. All of those are available in PDFs on the website, so keep that in mind as well. If there's any settlement or judgment over $3,000, then it must be reported to the California Acupuncture Board. So for example, if we had a claim and we defended someone and the payout was $2,999, we don't have to report that to the Acupuncture Board. Now, one thing that's new is that several states have gotten together to establish a single nationwide claims database. And that means that anything that is reported, it goes to this database. So now if you move from one state to another, or if someone, I should say, has a judgment against them, they decide to close up shop in one state, they move to another state to get another license. In the past, the second state didn't know there was a judgment against them in the first state. Now there is a national database where all the states can look at the historical records for a practitioner. All right, so now some claims foundations. So the most common claims that MIEC sees comes in 3 categories: needle-related injuries, which mostly means pneumothorax, burns or skin injuries, and then negligent treatment. So we'll get to what the burn and skin injuries includes in a moment, but the negligent treatment is kind of a catch-all, which includes adverse reactions to treatment such as painful treatment, lingering nerve pain after a treatment is over that may last for days or weeks afterwards, headache, brain fog, fainting, afibrillation, panic attack, swelling, smoke inhalation, infection, hematoma, and even a patient complaint that they're unhappy with their treatment. So it's kind of a catch-all. I looked at the last 10 years of data and there weren't enough numbers, like there may be a few in each of those categories. So I combined them all together, and generally we categorize that as negligent treatment. So the top 4 claims that we've had over the last 10 years is by far needle injuries. So pneumothorax is the highest. It's approximately 30% of our total claims. Negligent treatment is 20%. Burns, skin injuries is about 13%. And then I just included the inappropriate sexual misconduct at the top. People usually ask about that. So it's not that common, but it does happen. So we had about 7 examples of that in the last 10 years, which is not a lot, but it does happen. All right, so as far as skin injuries go, the prevalence is equal, 1/3, 1/3, 1/3. So 1/3 cupping. So that's really more blisters, obviously not burns, but blisters from cupping. 1/3 is heat lamps, burns from heat lamps, and 1/3 is burns from moxa. There's a small number that came from burns or skin injuries from heating pads. All right, what are the factors that drive lawsuits? So unanticipated costs. So basically, if an adverse outcomes do not become claims unless they have a significant impact on the patient. So if it is things such as, they have follow-up medical expenses and their insurance doesn't cover it, or they don't have medical insurance, or they've missed work, or they can't do the things that they used to do. So there was an example of a claim that I've heard of where a young woman was a yoga teacher and she was needled, kidney 3, practitioner needled kidney 3 as as was standard, didn't deviate from the standard of care, and it hit a nerve, and she had long-term pain, and she could no longer teach class, she could no longer go to school, and she had to move away and move back in with her parents because she was now disabled. So clearly that has a big impact, and so the claim would be brought for something like that. If the injury is severe, and also if a patient has a sense that they've been abandoned by their practitioner. So that could be that something went wrong and the practitioner didn't know how to respond to it appropriately. So they kind of stopped responding to the patient's phone calls or emails, etc., and they just kind of disappeared. Then that tends to make patients pretty upset. So what is the claims process? So everything starts as an incident. Some of them progress to become a complaint. So that complaint is made directly to the practitioner or submitted to the board. Or there's a notice of intent. The practitioner will be served with an intention, an indication that the patient has gone to a lawyer and they plan to make a formal complaint. And then a claim is what's considered where there's a demand for compensation. It's not just I'm upset, but it's a verbal, written, or informal or formal demand that I want to be compensated for the damages that have occurred due to this treatment. And then a lawsuit is formal legal proceeding. So how are cases resolved? So cases could be dismissed because they're standing or there's not standing. There could be motions for dismissal before trial, so dismissal upfront, or it could come later in the process. There could be a settlement. It could go to trial. If there is a trial, then you have to convince 9 out of the 12 jurors. Yeah, you need to convince 9 out of the 12 jurors for there to be a verdict. And then there's also arbitration. So at MIEC, we do not limit the way we handle claims to arbitration alone. I know some other carriers do, but we want to use every option that's available for us and when we address claims. All right, so now we're going to get into the case studies. Oh. All right, so as I said before, that all practitioners experience adverse events. So they're treatments that don't go as planned or cause unintended effects. Only some evolve to malpractice claims. So I frequently hear from licensed acupuncturists, as I told you before, that they've never had a claim. But I do believe that they've probably had events that have happened in their practice that maybe the patient wasn't upset, but something went awry. That's still considered an incident or an adverse event. So as we review these cases, I'd like you to think about your own experience where a treatment didn't go as planned. Did a patient have blisters after cupping? Was there ash from moxa that fell onto their skin? Whether it caused a burn or not, whether the patient noticed or not, has that happened to you? Have you had a patient that was dizzy after the treatment, needed help getting off the table? Or did you have anyone faint on you? Or did you have a patient call and say, I have a headache, ever since I had that treatment, or I've got pain and wherever, in my hand ever since you needled LI4. So please think about those things that have happened to you and think about how did you handle them? What did you think about? How did you respond to the patient? And if you don't have any of your own, think about something that has happened with a colleague of yours or something that you've read about on Acupuncturist Without Facebook, on Acupuncturist on Facebook.
And Marie, do you want people to put stuff into the chat, or do you want someone to raise their hand and talk, or are you just wanting everyone to kind of think on their
I
own?
want them to think about it, and then I'm going to go through some of the claims and kind of give them a framework for how we're looking at them, and then we'll have an opportunity for them to jump in.
Fantastic. Okay.
All right. I don't know why there's animation here. All right. So also want you to consider as we go through the case study was looking with a critical eye. What errors did the practitioner make? Was the standard of care followed? Did they overlook, omit, or was anything overlooked, omitted, or preventable? And how did communication, consent, and documentation affect the outcome? So the first case study we're going to go through is on cupping. So 25-year-old female with cervical radiculopathy. So the provider discussed the risks and obtained a written consent. There were 16 visits over 3 months without incident. The allegation was negligent cupping resulting from severe burns requiring additional care. And the reason it's called burns, even though they're blisters, that's the first aid approach that Western medicine would have to deal with a condition like this. So that's why they call it burns, and thus our claims department calls it burns. All right, so here are the sequence of events. The provider, the last time the patient came in, so they came in 16 times, that 16th time they came in, the patient was complaining of more severe neck and shoulder pain than the prior sessions. So the practitioner put the cups on and pumped one additional time more than they normally do to address the significant muscle tightness. Very quickly, 5 prominent blisters developed after the treatment. So the provider responded by treating the burns, referred the patient for medical intervention, and offered to cover the costs. The provider maintained contact with the patient, acknowledged possible overtreatment. So in this case, she did acknowledge that she made a mistake, likely made a mistake. I know that's often a concern, a question. Do I admit that I made a mistake? Do I not? That's not an easy answer. But in this case, this practitioner did admit that she likely overtreated, which caused the blisters. So the medical findings were that a second-degree burns caused severe pain, difficulty sleeping, and wearing clothes. So critical issues in this case is the patient, after the patient thought about it, did not come back for a while, thought about it, and then wanted to request their medical records and retained an attorney. They submitted an intent to sue, and the settlement was for just under $30,000. So from our claims department's perspective, it's a clear case of liability. So there was no need for them to get expert witnesses on this case. And the provider communicated to the claims department that she wanted to resolve the matter. Didn't want to take it to court, didn't want to fight it, but wanted to do whatever it took to resolve the matter. So the case ultimately settled for $16,000 during formal negotiations. It settled before a civil complaint was filed, and it was reported to the California Acupuncture Board, but there was no investigation. I don't have details as to why there was not an investigation, but it was reported because it was over that $3,000 threshold. All right, so what went wrong? So it was determined that the excessive suction with the extra pump on the cup was beyond the therapeutic level. So when I've mentioned standard of care, this is what speaks to that we should have an idea. We do know as practitioners what is the appropriate administering of different therapies. And sometimes it is sometimes we do want to go and, extra needles or extra, pump on the cup beyond what we know is standard of care. Sometimes when that happens, things can go wrong. it was determined that the practitioner failed to adjust her technique based on the patient's tissues response. So I don't know if she was in the room when the blisters came up, or if she was out of the room. But they're saying that she failed to adjust the technique appropriately for the patient. And it does indicate that it wasn't clear how much time had passed when she left the room and when she came back into the room. There was inadequate consideration of increased risk with the additional pumping, as I said, and that this was a change from the established protocol that she had been using at the prior treatments. So in general, it was a preventable injury that could have been avoided. So what went right? So it's just important to, when we look at case studies, to look at what went wrong, but what went right. So there was an immediate response. So the practitioner immediately acknowledged what went wrong and she treated the injury. She maintained supportive communication with the patient throughout the whole process. She contacted her malpractice carrier immediately, and she had a well-established process for informed consent and documentation. And from the company's perspective, they said that the benefit is that it was a quick resolution and it focused only on damages. There was a lower indemnity expense than going to court, and it was resolved in weeks versus months or years. So with this, we have to remember that it's stressful to go through a claim, right? So if it can be resolved quickly, it's better for the practitioner, it's better for the patient, it's better all the way around. And, you know, even if your insurance is there to cover you, whether you are negligent or not. So in this case, there was obvious negligence. So the insurance company, this is why you have the insurance, so they can come in and they can pay for that damage that is done. All right, so we're going to move on to another case study here. We'll take a break after this one to go through any questions that you might have. So the next case study is on a pneumothorax. So a 25-year-old male with multiple complaints, so musculoskeletal pain from the upper back, arms, hips, legs, swollen joints, tinnitus, stress. The receptionist provided the consent form that mentioned pneumothorax risk. The allegation is that there was a negligent placement of needles to the neck and scapular area, resulting in the pneumothorax and requiring medical intervention. So according to the documentation, the SOAP notes, needles were put in multiple points in the limbs and behind the ear. There were no immediate complications. The next day, the patient developed chest pain and shortness of breath, went to the emergency room, and a large pneumothorax was confirmed on imaging. It required a thorovent suction and chest tubes to be surgically inserted. And the complication was if the patient had a second pneumothorax 2 years later, requiring hospitalization. The case was settled for $115,000 at mediation. It did not go to trial. It was reported to the California Acupuncture Board, and an investigation was triggered. The secondary pneumothorax was likely related to the first incident, and that's part of why the case settled. The liability amount, the indemnity amount went up, and the impact on the patient was pain and suffering, medical expenses, lost wages, ongoing risk. So the impact was very significant. So what went wrong? So the provider denied placing needles near the neck and scapula. So verbally denied it, but the records showed, the documentation showed that the scapula was treated. The practitioner also relied on the receptionist to gather the informed consent, but they did not actually discuss it with the patient themselves. So we're going to get into that later about how do you do proper informed consent. Hint, you have to do it verbally, not just written down. And an expert witness indicated that there was poor documentation and improper informed consent. All right, so key lessons. Pneumothorax is a known risk of acupuncture, and just because it's a known risk does not absolve the provider from liability. So even if the patient signs the consent form and it says that this is a possibility, if it happens, it doesn't absolve the practitioner from liability. A claim can still be submitted. And then, as I said, informed consent really is about the verbal discussion you have with a patient, and then you document that discussion in the chart notes, and you have a signed written consent form in the chart as well. And clear, consistent documentation increases your defense and mitigates weaknesses in the case. So in this situation, because there was not clear documentation, and the communication with the staff and the lawyers saying, I didn't put those points in, but the documentation said that you did, then that decreases someone's defensibility. All right, so there, I'm ready for questions, or if anyone has any examples of their own that they would like to share.
Yeah, I just wanted Anne Marie to share with you that Teresa asked, do you ever see claims related to herbs? And if you could speak to that.
You know, we do see some claims related to herbs, and they're usually because someone has digestive discomfort afterwards. So they're very minimal. We don't see them very often. And they're rarely severe.
There's another question about the second case study. The person, Devin, is asking, so the provider lied about needling the chest and upper back? Would it be considered deceptive in that way, or just their testimony was different than the documentation? Was that the case? To understand that.
That's what it sounds like. So the claims department gave me a write-up for this case study. And from what they indicated is that the practitioner told them one thing, but the notes said something else. So that there did seem to be, whether it was intentional or not, I don't know, right? I don't know, because it said that a second pneumothorax happened. It isn't clear to me, and I haven't gotten a clear answer on when that claim was submitted, right? So if there was a 2-year time period between when the treatment occurred and then the second pneumothorax was 2 years later, right? I don't know that much about that, but it could be that the practitioner was asked a time later, right? Did you do this? And so it was not an intentional, misleading, but if it happened close together and the practitioner said, no, I didn't do it, where the notes clearly say they did, then, then it doesn't match.
Great. Thanks for clarifying that. Good question. Another good question from the group, from Grace. Is there a different standard for us? I think Grace means licensed acupuncturist. Is there a different standard for us than other medical professionals with regard to obtaining verbal informed consent? I've never had a medical provider obtain verbal informed consent from me on anything ever that I can recollect.
Right. It is the same for all medical practitioners. So I think that that's a very good point, that how many of us, when we go to our, if we have a PCP, or if we go to urgent care, if we go to the emergency room, how are they doing their informed consent? And, or even if you're having a procedure done, right? Then how well are they explaining that to you verbally, or how much are they just giving you the sheet, the document to write it down? So it's really important to do the verbal consent, and it doesn't have to be long. There are ways that you can do it briefly that takes a minute or two, and you can even give them a handout afterwards. And it could be just, we all know that the informed consent document that we have, is 2 pages long, and it talks about herbs and cupping and needling, etc. And you don't have to go through the entire thing with them verbally at the first visit. If you know at that first visit that you're just going to be doing needles, then you can just go through verbally that part with them, right? If you're going to be adding on cupping at that visit, then you can go through the cupping with them verbally. You don't have to add on the herbs and everything else. I would also recommend that in the future, like if the first 5 treatments, you just do needles, you add cupping or gua sha at a future a treatment, then do a verbal consent again with them when you introduce a new modality.
Great. Thank you for that. And then actually Sharon is asking, is verbal consent, is there a verbal requirement for all states? And I know you may or may not be able to speak to that, or a database where we could find that out.
I don't know.
Yeah.
I don't know. I think that whether it's required or not, it's a really good habit to have.
Yeah.
And one that I find that if you, this is anecdotal, but if you do that and get in the good habit of doing that, the chances of you having a claim is going to decrease even more.
Yeah. And we're building a case to protect ourselves and our
Yeah.
practices. So
Yeah.
the better we do these things and document that they were done,
Yes.
the more protection there's. And then just one last comment from Bill. Bill saying, hi, Anne Marie, I'm an expert witness for the CAB for herbal adverse events.
Oh,
There
great.
was a death that occurred, but evidence showed that it was due to alcoholic hepatitis and not the herbs. So
Oh, interesting.
how great to have an expert witness. Thanks for being here, Bill.
Well, Bill, I should reach out to you because, I can connect you with people at the, in our claims department. So we're always looking for more expert witnesses.
Right. And then, so Anne Marie, I just want to say we're at 7:50, and I would say sometime in the next 20 minutes or so would be a good time, whenever it feels right for your presentation tonight, to give everyone maybe a 10-minute bio break.
Yeah, now's a good time.
Oh, okay, great. So we'll come back here at 8:02, everyone. So 8:02, I'll put it in the chat. And if you have other questions for Anne Marie, go ahead and put them in the chat right now. Go get some tea, right? We're drinking tea together, learning about
That's
the
right.
medicine. Thanks for being here, Anne
Come
Marie.
on.
We'll see you guys. Great. Yeah, some bucha. See you guys in 10 minutes. All right, everyone. I hope you're coming back. I hope we all got tea. We'll just take a minute to hear the noise on the computer and stroll back over. We have a little more time together tonight. We're just starting to get into this. And we had Anne Marie come and talk at our Yosan event that happened last May. We'll be doing another one this May. And yeah, it was so well regarded. And that information, like we talk about this in school, right? And then it's like, where else do we keep getting this information about how to run a safe practice, how to make sure we're taking care of ourselves? And that ultimately means we're taking care of all of our wider patient population. Because when we take care of our practice and our patients with good documentation and really understanding best practices and the laws, it really helps us deliver this medicine with the expertise that our profession cultivates. So Anne Marie, thanks for guiding us through that. So, okay, well, we're back. And Anne Marie, I'm going to just let you get started in 1 second. We have our president here. I just wanted Julie to come on and say hi. Julie, I just asked you to be a panelist. Hopefully you got that invitation there. I see there's 2 of you logged in. I'm not sure if you're on 2 devices. So I am inviting you on both of those. Julia, did you get those? All right, well, we'll wait for, oh, here she comes. Yay. Julie, I just thank you so much for being here and for being our CSOMA president. And I just wanted you to say hi to everyone and just so appreciate your leadership in CSOMA and how you keep our team going. So Julie Tran, Dr. Julie Tran.
Hi, everybody. Thank you for joining us this evening. Thank you, Ms. Anne-Marie, for enlightening us and making sure our practice stays safe and our patients stay safe because this information is well needed. So join us in 2026 for our 2 live events, May 1st and 2nd at Yosan University in Los Angeles, and then September 24th and 25th in Oakland, right? And remember, if we go in September, we can celebrate my birthday. Let's do it.
We're gonna get cake, so make sure you come out in September if you're in the Bay Area. So Julie just got back for symposium, as I bet a lot of people here, and Anne Marie also. So yeah, thanks for being at symposium. All right. So Anne Marie, I'm going to turn it back over to you.
All right, so we're going to move on to another case study. This time is a heat lamp burn. 70-year-old male with restless leg syndrome and arm and leg tremors. The practitioner collected a partial medical history. They noted that there was a history of a stroke. The patient did sign a consent form, which included moxibustion and heat lamp. The allegation was that there was a negligent heat lamp application resulting in a severe burn to the right foot. So the patient was positioned prone with the feet on a bolster. Needles were inserted. A lamp was placed above both feet for a planned 30 to 40 minutes. The patient yelled for help after 15 to 20 minutes, complaining of foot pain. The assistant checked minutes later and removed the lamp. The patient left the office without additional complaint. The next day, the patient's wife reported to the practitioner 3rd-degree burns on the right heel. There was no needles that were inserted in the right heel, so it was thought to be attributed to the heat lamp. The patient ended up going to see their medical doctor, and there was some non-healing wound that required multiple surgeries. The patient also needed hyperbaric therapy and angioplasty for circulation. So the severity, the patient needed significant ongoing medical intervention. So there are some critical issues about this case, that the patient had Parkinson's but was not reported to the practitioner, and the practitioner did not ask about that during the intake. So the patient denied being informed about the heat lamp use. So this is an example of, even though it was in the written consent form and the patient signed it, because they didn't have a verbal conversation about it, then the patient can very easily say, I don't remember being told about it. I don't know about you, but I certainly don't remember most of the things that are in consent forms that I sign. So apparently that the patient, when they called for help, someone did not come to help right away. So the patient called for help multiple times before staff responded. And the patient claimed the patient had a blister, but the blister was apparent when the patient left. So heat lamp. So if a patient has peripheral neuropathy or it's condition in which they have decreased sensation, then it is actually a contraindication for heat application. So the outcome, the case was settled for $275,000, mandatory report to the California Acupuncture Board, and they did do an investigation. So there were multiple practice failures contributing to the incident. And the settlement was substantially higher than other case examples, partly because of the severity and the multiple follow-up care that the patient needed. So what went wrong? So a partial medical history was obtained. So there were 3 pages in the practitioner's form, and the patient only filled out 1. So even if the patient doesn't fill it out, it is our responsibility to go back to the patient and say, you need to fill out the rest of it. Or you need to go through the form with the patient verbally and fill everything out. But the consent form didn't specifically state there's a risk of burn from a heat lamp. And then the heat lamp was placed unsafely and without patient education is what the determination was. There was no system for the patient to alert staff. So common uses of, what's commonly I'm aware of is that there's a bell or a doorbell mechanism or some way for the patient to let someone know. There was not one in place in this situation. And apparently the progress notes, the practitioner had rewritten their progress notes and they had destroyed the original notes. So obviously that is not something that should be done. And that there was lack of consistent procedures for heat application. So what that means is that the practitioner didn't have like a standard protocol for how close or how far away they put the heat lamp to the patient's skin. So, it should be consistent, right? Even if a patient says that they want it closer, then we have to develop standards in our offices for how close that heat lamp can actually be to someone's skin. All right, so of those 3 case studies, common pitfalls across all 3 was lack of informed consent, incomplete or missing medical history, lack of or poor documentation, and deviations from standard of care. So hold on. One thing I want to mention too about these pitfalls is that all of these are within our control as practitioners. So these are things that also influence your defensibility. So if these weren't followed, then the defense for the lawyer can only defend you as much as you are following standards of care and doing documentation and doing your informed consent. So while your policy may cover you for any negligence, if you don't have the lawyer can only defend you and you can only win your case if you have these other things in place. And if you don't, then the cost of the award grows with each one of these that's missing. All right, so now I want to step back. We got into this with questions a little bit before the break, but I want to jump back into that. I'd like to have a discussion where we can talk about different experiences of your own where treatment didn't go as planned. What happened? What prevented it from becoming a claim? So as I said earlier, not everything turns into a claim, but there are a lot of incidences, there are a lot of adverse events that we can learn from, near misses, as I like to call them, is that, so what prevented them from becoming a claim? Was it just a lucky, was it just lucky that the patient didn't get upset and say something? And then what would you do differently? So if you know that a mistake was made, even if it was minor, did you implement a change in your practice? What did you do differently, or what do you think you could do differently to address it in the future? So I'd love for you to help me with that. See if there's any comments in the chat. If anybody would like to raise their hand, and I think you have the ability to bring someone in verbally, right? If they want to share.
I do, yeah. So if you want to, you can log in your a question or anything into the chat. If you have something you want to share, and we really welcome that, because chances are your experience is many other people's in the audience. So you really help us deepen this knowledge by participating. I can bring you up just your voice, or if you want to come on video, that's super fun too. So so go ahead and you can raise your hand, I think, in the, oh no, I think I would have to see it go in the chat, and then I'll ask you from there. And then also, Anne-Marie, while people are thinking of some cases, there's a couple questions. Jessica asked, what is considered proper and complete verbal consent?
We will get to that in the
Okay.
next section.
Awesome. So great question, Jessica. Way to set up the second half of the class for us already. Bam, I love that. And then Devin, as an aside, is it better from a liability perspective to use an EMR or paper files?
From a liability perspective, I would imagine EHR is better. And the reason is that you can be more efficient. You can set things up such that you can be much more thorough about everything that you are covering, every notes that you're making notes in the chart. You can collect more information, right? You can upload different documents that the patient may give you. You also have to sign it at the bottom, right? So you sign it and you close the chart, and that sort of locks it in, and it prevents you from going back in and altering records, which is a huge no-no from a liability perspective. So it just makes things much more clean and efficient, and it does actually protect you more. And I know that when I was in clinic, I started off doing paper charts, and because I got out before all of these EHRs started becoming more available. So I was doing everything by hand, and I know that I missed things. But when I started using Jane, I was able to set up, it's a modular system. So I was able to set it up where I could drop in different sections I needed for each patient, and then I could check different boxes. And it would keep me on track of asking everything I was supposed to ask. Am I charting all of the needles? What depth did I needle? What angle did I needle? What was my treatment plan and my follow-up? And then I could sign it at the end of the day. So it really took my charting from basic to, Cadillac, Mercedes level, right? Very quickly. And I was able to actually be more thorough because I was more efficient. So the more thorough, and I'll get to this in the risk management section, the more thorough you are, the better.
Great. Hey, Mary, I just gave you permission to talk if you're willing to ask Anne-Marie your question.
Hi, thank you. So I know with the insurance plan that I've had in the past, you can buy different plans where one, you have to have this signed form on two sides, and then in another plan, you don't have to have that signed, but you do need to provide a verbal, I don't know what you call it, like you informed consent, and inform the patient of possible risks, but you don't have to have the form signed. So I've always wondered, I have the patient sign the form no matter what, but I've always wondered what would be better.
So you're saying that the policy didn't require a signed consent, just a statement that you had a verbal consent discussion with the patient?
Yes, that's correct.
Hmm. I have not heard of that. I know that I've heard of a requirement for an arbitration form as well as use of a carrier's consent form, written consent form, but I haven't heard of your situation.
Okay.
But it's a good idea to have both, to have a written consent form and to then discuss with the patient verbally.
Okay, so this is maybe the confusion that I had. So
Mhm.
the consent form, I mean, I have the patient sign both sides because I
Mhm.
don't want to get into trouble.
Mhm.
Um, but this may be the confusion that I'm getting from some colleagues. I'm assuming that the consent form must be signed, but the arbitration would then be not necessary with that other plan.
Yeah, I mean, if it's with the particular policy I'm thinking of that requires an arbitration, right? For that
Right.
policy to, if you have that program with them and you don't sign, you don't have the patient sign that arbitration form, they will deny claims that come from that treatment
Right.
or from
And
that
then
patient, right?
okay. Right.
So did I answer your question?
You did. Thank you so much.
Yeah, of course.
Great. All right. Thanks, Mary. Okay, and then just two more things, Anne Marie. So thanks for making time for everyone's questions. And the questions are so good. We all have the same ones. So Grace is asking, actually, Grace, I'm just gonna find you and invite you to come on and talk because you're so much more interesting. So there's an invitation for you to join on mic, Grace, if you're willing to. Did that work?
And you're currently muted, Grace, so unmute, please.
There, I just asked you to unmute if you're willing to. Okay, I'm going to ask for you, but if you want to come on, go ahead. So Grace is asking, is there a specific reason Acupuncture Select excludes coverage for direct moxa, even though it had no greater risk than cupping in the data presented? I don't know if you know about that specifically.
So direct moxa, which is with the intention to cause a burn, right? So Japanese style, where you're intending to cause a burn, is excluded, as far as I know, from every policy and every carrier's policy. So indirect moxa, so pull or the moxa on the needle or a moxa box or any of that where there is a barrier, that is covered. And the reason is if there is an intentional, if there's an intention to cause a burn, that opens up the carrier to claims. So even if the practitioner tells the patients what they're doing, right, gives them a handout and says that you may have an infection, here's how to take care of this, like there's just such an increased opportunity for there to be an infection with a break in the skin, that is why it's not covered.
Great. Thank you, Anne-Marie. Julie has a question, has a case in mind.
Oh, great.
And also, I think someone else, like Christy, someone else. So Christy is also open to sharing. So Christy is under Julie's allowed to talk. Okay, Christy, are you there?
Am I here?
Yeah,
Yeah,
you're listed as Julie #2, but that's okay. That's just how you logged in.
Yeah, sorry guys. We're both on the board together and I logged into the wrong thing.
Okay, so got a case for us.
So I have a case. A while ago, I have renters And the renters apparently didn't collect all the needles. And one of the needles, you guys, fell in between,
Yep.
you know, when you have the headrest and they put their hands on the little shelf under the headrest. There was a needle right in the little Velcro part, and a patient hit it. And so nothing happened. I mean, they got poked by it, and that freaked me out beyond belief. This was probably 10 years ago. And Anne Marie, I have questions for you. So when I decided to talk to all my colleagues, they said, don't call don't call your insurance carrier, because until they report it, because then
Right.
making yourself more liable, or they're going to cut you.
Right.
And in the end, I called my insurance carrier, but it was on a Friday, so I freaked out all weekend. And in the end, nothing happened. Like I offered to, pay for a service if she wanted to get, checked,
Right.
the needle injury, all this stuff. But what's your take on that? I figure that's something you should tell us. I mean, I know now the answer, but
Yeah, no, that is great. And actually, it's a perfect example of why you have insurance, and because and patients can sue for any reason, whether you did it or not. So like in this case, you weren't the treating practitioner, it was left over from someone else, right? But there's still exposure for you if it's one of your patients. Now it is that question of, do you report this to your carrier or not? So I'm going to kind of give you a couple different ways to look at this. One is, everyone needs to read your policy and look and see what mandatory reporting is in your policy. It's going to be similar across them, but you need to know what your exact policy says. And I venture to guess that it's going to say, when you become aware of any incident, you are to report that to your malpractice carrier, whether the patient is involved or not. You notice something goes wrong, you have to report that. Because if later, if you knew, and the patient, and you've been having conversations with the patient, and then a month goes by and the patient then decides, first the patient says, oh, it's fine, it's no big deal. But a month or two goes by and then the patient goes, no, actually, I want to say something. And your carrier finds out that you didn't report it when you knew about it, they could deny your claim. So get your policy, read it, know what it says. What I can tell you about MIEC is that we don't approach this from an adversarial perspective. We encourage, yes, the policy says that you have to report when you hear something, but our philosophy around that is, call us. We're here to help you, right? We do not have it is not customary for the claims department to talk to the underwriting department. This person has called this many times, or this person has reported this many, incidences. They don't talk to each other in order to decide whether to cancel a policy or to deny a claim or raise your rates or something like that. So that's how MIEC handles it. As I said before, we're a mutual company, so we want to be there for our members, right? We don't have a profit motive, which means we exist to take care of our members. And 75% of the calls that our claims reps get are what we call advice calls. Something happened, I don't know what to do. So they'll take documentation of what happened, get contemporaneous notes in the system. So then if something progresses in the future, our lawyers are already 1 or 2 steps ahead. And it allows you to start to get your documentation in line and things like that. It doesn't have to be scary. So at least that's how MIEC approaches it. But you need to know who your carrier is, what their requirements are, and I would even say call them. Right? You should be able to call your carrier. They should not be scary to you. At least that's my perspective. You're paying for a service, and you should be able to contact them and say, how do you want me to do this? What are the requirements? Give them a scenario. If this happens, tell me what would you do, or what do you recommend that I do? Find out, how easy is it for you to get a hold of them? Do they respond, right? Are they willing to talk with you about those kinds of things? Are they generous with their time and their advice? And that's sort of a preemptive, hey, let me give you a scenario, what might happen. But you can get a pretty good sense of whether they're going to be there for you if something was to happen. And it also lets you know exactly what you are supposed to do in case something does happen. I feel pretty strongly about that. Your insurance company is there for a reason. You're paying them for a service. So you should be able to get the support that you need from them, no questions asked.
That's so great. Thank you for that. I know it can be easy to think, oh, I made a mistake, and we can have shame or embarrassment, fear,
Totally.
all kinds of emotional responses that can interfere with thinking when incidences do
Yeah.
come up. And since they don't come up often for any one of us, right, then it's usually a new situation. So
Right. So then I have a question for Christy. And
Yes.
she's still, Christy, are you still there?
Yep, I'm here.
So what did you do after finding out about this incident? Did you change any practices in your clinic about needles or for your renters or things like that? How did you handle it to prevent that from happening again?
Well, I surely check that headrest every single time I ever put someone face down again. And then the other thing I did that I knew to do, like, or maybe after I talked to my insurance carrier at the time, they said, document everything you offered the patient and everything that ever happened. But truthfully, you can try to ask your renters to like count their needles or do whatever, but you don't have I learned I just don't have I still have a renter right now who honestly, probably once a month I see needles on the floor when I come in on Monday. And I just know, okay, now I have to check for needles on the floor before I go to work because my surface area has to be clean.
Yeah.
So I sort of like, no matter how much I have that conversation, it's not changing.
Yeah.
You guys can't change other people's behaviors, I've realized.
Yeah. And that's real world, right? Like
Yeah.
sometimes you could say, well, someone's not gonna, I have a renter, I'm gonna not let them renew with me, right?
Right.
Because
Yeah.
they can't keep things safe. But that's not always the case. We can't always do that. Maybe we need their their income, right, from using the room, and they're not, super dangerous. So then you can adjust things that you do to make sure that you're providing a safe environment for your patients.
Right. And I think, I know that that's what she does. So that's where I look. So like that.
Right.
So you sort of get used to your renters and what they do. But yeah, I definitely think it's important to, have that conversation with them. And I just learned to document, if any incident like that happens, document right away what you offered and everything.
Yeah, agreed.
all right. Thank you, Christy. Christy's another CSOMA board member, and thank you just for your decade plus of a service to our profession through CSOMA, Christy and Julie. Hey, so Jessica, I'm going to invite you to talk if you're willing to. So I'm going to allow you to talk because you've got a great question in here that I think a lot of us have. Are you able to unmute and talk?
Hi, can you hear me?
Yeah.
Yes, hi.
Hi, I just had a question. It's not a case, but I wanted to go back to something you briefly mentioned about the needle depths and angles. And I remember running into this question in the past.
Yeah.
I just wanted to hear your recommendation, how critical it is to record each needle depth and angle, or if standard language covers it, like they were all, needles were inserted using standard depths and angles adjusted for the patient.
Right.
Is that sufficient?
I'm going to say a qualified maybe. And the reason I say I'm hedging my bets is because that crosses between sort of standard of care and liability. So I can't, as someone representing an insurance company, tell you exactly how your documentation should be. That's really about, as a professional or as the profession, standard of care, you guys determining for yourselves what you think is sufficient. Because if I tell you, you have to do it this way, or on this call, I tell, these 50 people, you have to do it this way, and I'm wrong, or if a different carrier sees it a different way, then you could be harmed, right? And so what I can just tell you from a defensibility perspective, that if there was a claim, the lawyers are going to look at your notes. And if your notes are thorough, reasonable, doesn't mean they have to be like every I dotted and every T crossed. But if they are reasonable and sufficient and someone can read through and get a good idea of what was done, how it was done, that someone could recreate it, then that is sufficient. And the reason I added this to the conversation was that I took a class from Anthony Vondermoel. I don't know, some of us know him. He has a really great class on avoiding lawsuits, and it's a 5-part series, and one of them is on standards of care. So he was the one that said, as an expert witness himself, he was involved in a case where there wasn't sufficient documentation on the needles, needle depth, needle angle, etc. And I believe it was a pneumothorax that was, related to GB21, that if you had had that information of the angle, right, of the depth, that would have provided more information to help with that practitioner's defense. So it's really more, it's not required, but it's as I have learned more and talked to other, teachers on these topics, they are providing lessons learned. And so I wanted to pass that on as well.
Great.
Okay, that makes sense. Thank you.
You're welcome.
Thanks so much, Jessica. Okay, there's one last one that I'm seeing. Do we have time for one more, Anne-Marie?
Yeah.
Okay, Mary, I want to bring you back on. This is a really interesting question about a pneumothorax. So Mary, I just invited you to talk if you're willing to share.
Hi, thank you. This is such a great presentation. Thank you so much.
Oh, you're welcome.
Yeah. So it was actually one of the people who was part of training me who told me a story and said, "Oh yeah, I've caused pneumothorax before." And I listened with a stethoscope and I could hear the crackling. And the patient just had some pain, and I told the patient to just go home and not engage in any strenuous exercise, not get on an airplane. And I'm mortified as I'm listening. And um and I was told the patient was fine, that the practitioner said, this is what happened. You're okay. It's a tiny thing. It's not going to cause any problems. Um, so, and the practitioner checked in with the patient day after day. About 3 days later, it was all gone. And but it actually made me more careful with my chest needling and my upper back needling. But I'm curious if that were to happen, because I train people, so I need to know what to say when people ask me questions.
Right.
Should that practitioner have actually contacted their insurance carrier and said, hey, this happened?
I want to start by saying, as a practitioner, what do you think is the standard of care if that was to happen?
I would think that you would document everything and come forth with the utmost of ethics and professionalism. So, I mean, to me, you would document it, and you would make sure that, but I don't, that's the other part I don't know. Do you tell your
Yeah.
insurance company or just document it?
Right. So I would add that part of the standard of care is to refer the patient. So
Yes,
there is the
okay.
piece of of documentation, etc. But the standard of care is, if something like that happens, and because a pneumothorax is a big deal and it can be life-threatening for people, you refer it. Even if you determine that it is small, your professional ethics and responsibility is to that patient and for them to get, harmed. So,
Okay, great.
and this actually brings up a really good point about standard of care versus defensibility. And I alluded to this in, just the previous question, is that an insurance company, we are concerned with two things. Is it covered? Is it defensible? So is it covered? Does your policy cover what you did? Is it within your scope of practice and it doesn't meet one of the exclusions? If that's a yes, whether you are negligent or not, they have a duty to defend you. Then the defense part is everything that you have, documentation or policies and procedures, communication, informed consent, all of that stuff that you can provide to show that you were following the standard of care, that you know, did what you were supposed to do, and so that the lawyer has something to defend you by. But that standard of care piece of it is determined by a wide number of things that insurance companies, we can't wade into the standard of care because we're not clinicians. They, you know, they have to sort of like hands off from that perspective.
Mm.
And that is where you guys as practitioners, or the C&T manual, the CEU classes that you take, the schools, all of that goes together to create the standard of care. So in this case, I would break it down and say, whether what you should do or you should teach other, you know, students that you're helping now is talk about it in those terms. What is the
Mhm.
standard of care? Is it something that what would a reasonable practitioner do in that case?
Thank you for this. This was the person that I'm referring to was also a medical doctor, so maybe that's why he did not. I don't know. I don't know if he can cover
It
his
might
own
be.
mistake,
Yeah, it
but
might be, but I would bet that if that went to court, that that practitioner as a medical doctor would actually have, like, they would be held to the high standard of referral,
yeah,
right?
great.
But
Thank you. This is what I'm teaching to people too. So great.
yeah,
Thank you.
yeah, you're welcome. And document, document, document.
All right. Great. Really good participation and questions, and I'm learning so much. So, yeah.
Okay, perfect. You know what, I'm gonna throw myself out there and share something that's a little bit personal, I guess. So when I was in my first year or two out of practice, I was getting used to running two different rooms. And actually, no, maybe I was in year 5, but I was now running two different rooms. And I put cups on a patient, and then I got stuck in the other room with another patient, and I couldn't get away to go remove the cups. So when I came back 5 minutes longer than I should have, there were blisters under where the cups were. And like, obviously I was mortified, and some of them were quite large. And so I removed the cups, I communicated to the patient what happened, I got the first aid kit, and I dressed it appropriately. And they weren't concerned, they weren't upset. But I didn't have at the time an incident report. I didn't have like a procedure that was established ahead of time of how to account for that. I mean, obviously, I wrote it in the chart notes, but I realized that the clinic didn't have an incident report. And we didn't have a standard list of things we should do, of like following up with the patient. Like, it wasn't written down. It was just me remembering what I was supposed to do. So in that case, what I learned from that situation was to develop an incident report, to actually have a list and keep track of when I called the patient, what they said, you know, how many times I called them, kind of like a call log. And then, you know, following up with them to make sure everything was okay. And then if they came in for another visit, right, to check and make sure that it was still okay. So it was, nothing ever happened. It didn't become a claim, but it was one of those near misses that could have gone bad really quickly. And it was just because of an accident of trying to manage patients and, you know, two patients and, you know, normal running a clinic. So something to consider as well.
Emery, there's one more question there coming
Yep,
from Grace, and it's just, is the CNT manual generally held as the most definitive standard of care?
it is definitely one of them. Yes.
Okay. And I have my own question.
Yeah. What's that?
Okay. Are we still in time? Is there time for it?
Yep.
Especially with, you know, when I think about what AI can do in a good way to support us, and I'm thinking about it because this doesn't sound fun to write, but is it a good idea for us that have our own clinics or practices? I work in a hospital, so I've had to do these types of things for the hospital,
Yep.
creating SOPs. So standard operating procedures about what we do with a heat lamp, how we, whatever it is, how we plug it in, like whatever
Yep.
device we're using, does that increase our defensibility if we have SOPs for our practices?
yes, I'm going to say, and then there's a caveat. So, and there will be a slide we get to in risk management about creating SOPs. And it is a good idea to have those in your clinic. And as you are writing them, it allows you to think through, well, what are the things that I should be looking at, right? What is the standard of care that I have learned from the different classes, or that I have learned from, being in practice for 10 years, or, so you add all that together, but you have to follow them. And I would even suggest, like, have an SOP, but don't make it so detailed. And this is where the caveat comes in. So I asked this question to several claims representatives at the company, and they kind of had this look on their face, and I was like, what? And they said, if it is too detailed and you deviate from those SOPs, the plaintiff's attorney will get you on that. So you got to balance having those SOPs as a way to help the clinic run more efficiently, right? And safety checks, things like that, but not so much that you have like this written Bible that then you've got this standard that you're holding yourself to. And if you don't follow something, then you're going to lose the case. So it's unfortunate, but that's the way it is.
All right, thanks.
Okay. All right, risk management. So in a nutshell, risk management is your accountability as a professional. It's proactive protection, both for you and your patients. And it prevention and mitigation, so it helps decrease the chances of things happening. And it also, as we've talked about multiple times, you're getting some themes that are going here. It supports with your legal defense. 3 levels of protection. I'd like you to think of it in this way. So there's prevention, then there's response, and then there's protection, right? So you want to avoid incidences before they occur as much as possible. Plan so that you can reduce your chances. Then if something does happen, you can manage the event effectively when it does happen. And then the protection part is making sure that you have the coverage from your malpractice policy and the coverage and support if a claim arises. So there's several elements of key elements of risk that we're going to talk about here, and that is documentation, informed consent, communication, common practices and processes. So similar to the presentation that I did in March in person at Yosan, that a lot of the questions that come prior to getting to this part of the presentation are already alluding to these topics. So the good thing about that is we're seeing a lot of themes over and over again. So one of your takeaways then after this presentation is over with is hopefully that you'll remember these top 3, maybe 4 things that you can do in your clinic right away. All right. Document, document, document. The claims reps always tell me, and even underwriting, if it's not documented, it didn't happen, and you will lose. You will lose the case if your documentation is absent, or it's minimal, or if you go back and try to change it, which we'll get into in a moment. So you want to create consistent charting habits. Not just that you do it every day, but that you do it within a certain time period. And that you're consistent as far as your thoroughness. So you don't want to have a little bit, just a few notes on one day, and then the next day you have extensive notes, or with this patient you have extensive notes, and this one you don't. You want to create consistent charting habits across the board. And you want to have thorough SOAP notes for all treatments. And that also means friends and family or freebies. So I've heard people say, oh, it's just my family, or it's just my friend. I'm not going to keep notes. You need to keep notes on everybody. So friends and family actually do submit claims. So it's not like just because you know them, they're not going to submit a claim. And whether you charge for that treatment or not is immaterial as to whether you should keep chart notes. Everyone is a patient. You are a practitioner for every situation. If they're another human being and you give them a treatment, you need to have chart notes. Another reason for this is, think about it. Even if you give your partner a treatment, if something went awry and they have to go to the hospital, you need to have chart notes to give to the doctor there. It's not about your liability and being afraid of your liability. It just means that maybe what happened, whether it was negligent or not, would be helpful to the next practitioner that treats your loved one. You also want to document every conversation, whether it's on phone, email, text, etc. Put that into your chart notes, include the name, contact number, content, advice given, etc. This is why an EHR is super helpful, because you can find efficient ways of doing this. I don't know exactly how you use AI in doing this, but that can help you as well, because otherwise it's very time consuming. So paper charts, it's going to take you a long time to do this. So you have to create some efficiencies in how you do things to make sure that you're checking all the boxes here. So thorough and timely documentation. So you want to document contemporaneously, sign promptly. So you can have where you give yourself like 24 hours or 48 hours or 72 hours to finish your notes, but don't wait a week, right? Don't wait a couple of weeks. You want to get into a habit of setting aside the time to make sure that that's done and to sign it and close that chart at, within that time frame. And never, never, never alter existing records. You will destroy your defense, and your insurance company will likely drop you. Even MIEC, we have dropped someone because he was explicit, or they, I should say, they were explicitly told not to alter their notes. And what happened is that most of their notes were pretty sparse. And a year later, a claim came in, and they went back to that chart because they hadn't actually signed any of them through their EHR, and they went in and made very detailed notes for that treatment. So not only did they make the notes a year later, but so their memory is not going to be as good. But there was a marked difference between the amount of information on that note versus other ones. So did lose the case. The case went from an initial $20,000 settlement to $150,000 because they falsified the record, and MIEC canceled them. So that is one where you don't want to cross that line. If you need to make an amendment, you can go in and make an amendment, but you don't want to go in and alter the other records. And let's see here. Okay. Soap notes. All right, so here are some pro tips on that. Include progress assessments at every single visit. So again, this gets back to how detailed your subjective section is you don't have to, as you know, go through every single evaluation, but you should be asking, has anything changed? What's better? What's worse, etc. And then obviously that flows into what the treatment that you do. Document the needle angle, depth, not just location, and notate when and how the needles were inserted. What I mean is, did you insert them all at once and the patient laid on the table for 30 minutes by themselves or 45 minutes by themselves? Or did you come in, you do one set, then you came in and you removed them and put in new, or you did cupping and then you put, just be detailed about what you did, when you did it, put timestamps in there. And then that needs to match your billing codes. So sometimes there can be a claim that's related to billing, or that may sort of open the door. If those don't match, that can cause problems too. And as I said, customize your EHR to make it more efficient and thorough. You can also take documentation courses to improve your skills. And I even suggest looking at the soap notes, if you go see your own doctor, or if you have the ability to look at soap notes from medical doctors, they're really fast at this, and usually pretty thorough, at least the ones that I've seen. So that's another way, if you want to really boost your documentation skills, that's one ways to look at what is a good example and model yourself towards that. Special documentation. So these are the things I mentioned, is you want to have some documentation ready if there is, so like for an incident report or emergency plan for adverse events. They don't have to be perfect. They just need to exist and you need to use them. All right. Second thing, informed consent. So there's different types of consent. Simple consent, so for treatments with no risk or injury. Full consent is required for treatments with material risk. So it includes a discussion of benefit, risks, alternative. That's usually what we're going to be doing with a new patient. And then implied consent applies to repeated treatments unless a new risk arises. So generally, we do a full consent when patients are, the first time they see us, and then in the future, right, you can touch base and get their consent again. So as I said earlier, maybe you just do acupuncture and cupping the first 5 visits, and then you introduce gua sha, or you introduce herbs, or you introduce something else down the line. Then you want to have another verbal conversation with that patient and get their implied consent and chart that in your notes. You could even give them a copy of the informed consent pages that they signed early on. You can offer it. I mean, maybe that's going above and beyond. I tend to be above and beyond kind of person. So, take some of that with a grain of salt, but do your best. Try to be as thorough as you feel is reasonable. All right, obtain a full informed consent. Reconfirm, as I said, for new treatments or changing situations. You do want to talk about what the risks and the benefits and the alternatives are. Allow them a chance to ask questions, and then confirm, do you want to proceed? And chart that in the notes. Patient agreed to proceed with treatment. And then communicate that they have the option to withdraw their consent or stop treatment at any time. And again, consent form is only meaningful if the discussion occurred. All right, communication is another aspect. It is crucial. Both informal and informal communication matters. You want to be proactive rather than reactive. And like I said, what feels like over communication is probably appropriate. Patients don't want any surprises. They don't want to wonder what's going to happen. It needs to be super clear to them how you run your clinic, how the treatments are going to go. It's like, tell them we're going to do X, you're going to get on the table, and then I'm going to feel your pulse, look at your tongue, insert the needles. And then while you're going through that, you could reiterate again. And then at the end of the treatment, you could do a recap. We did X, we did Y, we did Z. Do you have any questions? You want to make sure that everything is really transparent. And it is overkill, but it actually provides most patients with a sense of comfort and increased confidence in you. As you get to know patients better, then you don't have to be as explicit, but it is a good idea to set that standard. Communication during treatment, again, no surprises. So giving verbal consent when you introduce new modalities, establish a check-in system for patients. And it's a good idea to give them take-home instructions. So that could be for cupping, right, or for gua sha. So what to expect. You're going to see some sha. You're going to see what looks like bruises. We call it sha, etc. If this happens, then this is how I want you to respond. If you notice something gets infected, call me. Or if this happens, go see your doctor, go to urgent care, etc., and give them a way to get a hold of you after hours. All right, practices and procedures. So standardization, systematizing things. So it does create reliable safety habits and document professional care. Establish written practice policies, provide the policies to patients at the initial visit, and implement systems for checking their medical history and treatment plans, informed consent. You could also, depending on how you have it set up, have it, if you have Jane, I'm familiar with Jane's, patients can log into their account and access some of these documents themselves. You know, maybe you have it somewhere on your website, but you could have it in places where patients can get a hold of it after the fact, or obviously they can contact you when, if they need another copy of it, if you don't want to make it readily available. I talked about this before, but develop an incident management process. So you want to have a protocol. So this would be one Raw asked about, should you have SOPs written down? This is one where I actually would write this down and I would think through all of this, is developing your adverse event protocol. Have an incident report, have a referral plan, have names of people you can refer them to, whether it's the hospital, urgent care, etc. Know what is in your area, have first aid supplies on hand and know how to use them, and call your malpractice carrier. Really important. Again, if you're with MIEC, then you know you can call me, you can call the main number, ask to talk to a claims representative, and they will guide you through all of this. Again, it doesn't have to be that the patient is upset, but you should have someone there to help guide you along the way. All right, I'm going to stop here for a moment. Rod, do you want to come in and see if anyone has any questions before I go on?
Yeah, that's great. And I just want to mention we're at 9 o'clock. So, you know, I would say maybe just go another 20 minutes and we just kind of, or like, you know, instead of having a second break,
Okay.
it's up to you if you wanted to take 5 minutes now and have everyone come back. So it's really
Let's go ahead and go through this part. It's towards the end of the presentation anyways, and then we can do the wrap up of Q&A at the end.
okay.
Okay.
Okay. So so no questions now. You want to keep
No
going?
questions. I just wanted to see if there was a burning question that was out there.
No, no burning questions.
Okay, got it.
Yeah,
And I'll move
great.
on. Okay.
Perfect.
All right. So risk management isn't just about avoiding claims. It's about upholding ethical practice and patient trust. So ethics and risk management go hand in hand, and at their core, both are about protecting your patients and protecting yourself. So we do have an ethical duty to prevent harm, and it's not just about avoiding errors, it's about anticipating risk, catching small issues before they become bigger ones. And clear communication and solid documentation aren't just administrative tasks, they are ethical obligations, and they ensure honesty and transparency and accountability in your patient care. And practicing within your boundaries means knowing when a situation is beyond your expertise, whether that's a complex condition, a distressed patient, or an area that requires medical referral. It's recognizing that and acting on that that's also part of your ethical professionalism. Every case we've discussed and every adverse event in your own experience involves an ethical decision. Somewhere along the line, we have to think about, what am I supposed to do? So maybe it was a moment when you didn't fully listen to a patient's concern, or you didn't gather all the pertinent health information, or you assumed that consent was understood and skipped the documentation. Those are ethical lapses that can open the door to claims. What's important to remember is that ethical action, communicating clearly, documenting fully, and responding to concerns all prevent risks. They all prevent incidences. And ethics is not abstract. It's the practical foundation for defensibility. So ethical behavior creates the record, the communication, and the trust that if something goes wrong, that you will be protected. So as far as the laws and the requirements for you is you can access these on the California Acupuncture Board's website. So there's the URL right there. And so you would just go to the Forms and Publications tab at the top and click on the first one. Now, this is added to on a regular basis. So I know that his Gron probably doubled in size in the last 10 or 15 years from when I last looked. So it's a good, it's really detailed and it can be really boring. I get it. But I suggest that you do get it. Just look at different sections along the way, you know, and just become familiar with what those are. There will be a lot of sections in there that don't apply to you. So, you know, there's a apprenticeship program, right? There's other detailed things that aren't going to apply to you. But as far as the regulations that you are required to do, which we're going to go into some of them, familiarize yourself with those so you know what to do. And it's not like a second, it's not, you're not guessing, what was it I was supposed to do? But that way, so you know what that is. And if you want, if you're going to create yourself some kind of SOP or, you know, policies and procedures for your clinic, you could just take pictures or sec those sections out of the laws and regs and put them into that binder so you can refer to them. All right. So practitioners must follow laws that protect patients and define professional boundaries. So that is informed consent, record keeping, being in your scope of practice, unprofessional conduct, regulatory compliance. So I'm not going to talk about the scope of practice, unprofessional conduct, and regulatory compliance here, but I am going to reinforce, you know, what are the legal requirements for you for informed consent and record keeping, since that's what we've been talking about. So informed consent, based on the California Acupuncture Board, you must explain the treatment, nature, the benefits, and the risk in plain language. You must obtain the patient's voluntary agreement and you must document the discussion. And again, if it's not documented, it didn't happen. Yes, you are required to maintain accurate, detailed, and timely records. This includes consent discussions, treatment rationale, and patient communication. And your records are there to protect you. They are your best defense if a claim arises. So as far as standard of practice go, this is where more the language that's in this laws and regulations must keep a complete and accurate records on each patient who is given an acupuncture treatment, including but not limited to treatments given and progress made as a result of the acupuncture treatments. You must use needles that are labeled for single use only that meet federal labeling requirements. And it shall constitute unprofessional conduct for an acupuncturist to needle more than once. So using the same needle more than once. I will say that, again, this is why you should also know your malpractice policy, is that it is one of the exclusions in MIEC's policy that if it is to be found that a needle was improperly reinserted, used more than once, or you're using non-disposable needles, then a claim will be denied. So I think this is hold on. I think this is the last one, right? So ethical practice supports legal compliance. So they go hand in hand and they both strengthen your defense. So good communication, documentation equals credibility, and following the laws also helps with your defense. And I do have a bonus since we've got a little bit extra time. We've got extra time, right, Ra?
We do.
Okay, great.
Yeah, I would say we have another, I would say we can end at 9:20 since we didn't do a second break. So that gives us about 15 minutes.
Oh, okay, great, great. So I wanted to add a bonus here to talk about some things that are not malpractice claims, but are related to the acupuncture board investigations. So dating patients, DUIs, or forgetting a patient. So these may not turn into malpractice claims, right? Because maybe they have not met the 4 criteria for it to be a malpractice claim, but you can get in trouble with the acupuncture board for any of these. So dating patients, I know that you've heard about this. It's just something to avoid. And I know it is avoided most of the time, but it just should be avoided. I do want to share a couple incidents that I've had. So when practitioners are interested in getting a policy with MIEC, then they talk to me and I explain to them what the policy is. And I also learn a little bit more about their situation and help answer questions about the application. Some of the questions in the application are, have you ever been denied coverage? Have you ever been canceled, et cetera, from a prior policy? So I've had 2 applicants or 2 prospects that talked to me, and both of them indicate the stories were very similar. Both of them had a patient. They decided they wanted to date. They ended the patient practitioner relationship. They did not wait an extended period of time before they started dating. So they started dating, and I think it was, and I'm kind of averaging both stories together again because they're very clear, but both of them dated this person between 6 to 12, these 2 different people, 6 to 12 months. And then it went south. So, and the person that they were dating got really upset and angry that the relationship ended. So they called the California Acupuncture Board and submitted a complaint. And I don't know exactly what the complaint said, but basically it explained that they felt taken advantage of, that that the practitioner should have known better and should not have dated them, and etc. So these people, they had their malpractice insurance company found out about it. They had their policy canceled, and one of them was practicing without coverage, and then the other one had to get a policy from a surplus carrier, which these are usually carriers that do non-traditional lines or more risky insureds. And he was paying $5,000 a year with a surplus carrier for his malpractice insurance because of that incident. So it's a big deal. So I wouldn't take that lightly. It could have consequences that you don't even think about. And if I remember correctly, I think one of them did have a consequence with the board and lost his ability to practice for about 6 months. A DUI. So this is one where if you are caught, if you are found to have a DUI, that gets reported, and the California Acupuncture Board can suspend your license or revoke your license depending on the situation. So this is also included, I believe, in the laws and regulations. So you really want to take this seriously. If you're going to be out and about at a restaurant, at a club, at somewhere, and you're going to be drinking more than you can be safely, drive home, get a Lyft, get an Uber, take a cab, do whatever you have to do. You do not want to get a DUI because it will impact your professional life. You are held to a higher standard than the average person because of your medical license. And then another incident that I want to share that I thought was really interesting is we had a applicant who forgot a patient. She was referred to the California Acupuncture Board. And she lost the ability to, I think her license was suspended for a year, I believe. And she was young and she was newly licensed. And the situation that she told me was that she started working for a clinic that was a very busy clinic, and that she was supposed to start seeing 3 patients an hour. And at one particular day, the front desk person went home early. It was a Friday, and she already had 3 rooms going, and someone walked in and said they wanted, and the clinic had advertised that walk-ins were welcome. So then someone had come in, another patient who did not have an appointment, who wanted an appointment. She told them no. The person kept pushing, and eventually she gave in and she put them in another room. And so she put needles in that person and then went back, to finish everyone else up. She said she felt frazzled by the end of the day. And so she was tired. She went home and she left that other person in the room, turned out the lights, and locked the door. and that person had to call 911, they had to break in, et cetera. So obviously there was a claim, and she lost her license for a while. It was suspended. So what she learned was that environment, that particular clinic environment, was not a healthy environment, right? They were pushing volume as opposed to safety. So she left that clinic, went off on her own, and established other, parameters and a speed, patient volume in which she could handle. But I wanted to share that is this is something we hope none of us want this to happen, but it also to give us pause to think about how does the environment in which we work, either we run the clinic ourselves and have people working for us, or we're working for someone else and we're in an environment that is unsafe for you and the patients, that is something that you want to address as well. And then as far as the laws and regulations for disciplinary action, the board may deny, suspend, revoke, or impose probationary conditions on a license upon the license of any acupuncturist if they are guilty of committing any one of the following: gross negligence, repeated negligent acts, or incompetence. So the case about leaving the patient in the clinic, that is considered gross negligence. Let's see, I think we can. All right, that's it.
All right. So just
I
viewing the chat here. Any other questions? We have this expert here. We've got another 5 minutes or so. A few takeaways that I always have, and I've gotten good at this in CSOMA because so often members and other people from the community will reach out and have questions for us. And so often I'll say, well, who's your insurance, your malpractice carrier? And say, like, that's who you want to call them. Start there because it's such a wealth of information. So
Yeah.
I feel like I've done that many times where I'm just not sure. And so so that it seems like that's a recommendation that you're making, Anne Marie,
Yes.
is
Yes. Call
not
them.
sure, call. You're sure?
Call them.
Right?
Be there, call them, get to know them, be friends with them. Like they are supposed to be there to help you, right? They shouldn't scare you, right? And if they do, something to consider, right?
Yeah. All right.
And I'll add, they should help you too, right? Find out what kind of risk mitigation resources that they have for you. What kind of resources can they can they offer you to help keep you safe and keep your patients safe?
Yeah. Yeah. Okay. Any last questions? I'm just reading through the chat. Any last questions here? Oh, so Julie's asking, can you give an example on how thorough we need informed consent to be, for example, for a heat lamp? Like how, Julie, can you elaborate on that question? I just want to make sure or is that Christy that was asking it?
It's Christy.
Okay, so hold on. Julie. Okay, Christy, can you just ask that question more?
Yeah. Like I never normally am like, here's a heat lamp. This is the possibilities. I mean, how do you want us to do this for a heat lamp? Like I can think of when a patient comes in and I'm going over a consent form, but in the room, like cupping, I would talk about, but heat lamp, I was thinking, I think I never do that. So what's your example, like putting you on the spot, Anne Marie? How would you say it so we know how to do it correctly?
I think what you could say is, if your situation warrants it, I may use a heat lamp to either help keep you warm while you're on the table or to provide therapeutic stimulation to, to your tissues, that it's not going to be, more than 6 inches, to your skin. Let me know if you have any heat sensitivities. Do you have any, sensation issues, like peripheral neuropathy, et cetera, where you don't have good sensation, right? Let me know whether you have those things. So then I can know to alter what I do or not use it. And then, do you have any questions? you know, does heat feel good to you? Does it not feel good to you? Right. And some patients might even say, and then during the treatment itself, some patients might say, oh, it feels so good. Can you move it closer? Right. So then this is outside that consent form discussion, but then you would have to say to them yes or no.
Yeah.
I
Okay.
mean, you know,
Right.
have your limits about what you are consistent with everyone.
Okay. So we're not required to be like, a heat lamp could possibly cause burns and blah, 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 blah. Like
I
that's
mean,
not,
yes, you should say one of the risks of a heat lamp is that it can cause burns,
I
right?
just feel like I know it just,
Well, what you could say is something like that. One of the risks of a heat lamp is that it could cause burns. We mitigate this by not putting it closer
that close.
than
Yeah.
X amount, right?
Okay.
So if you want it to be warmer, we'll find other ways to keep you warm while you're on the table. But
Okay.
they should know what the risk is and then how you're going to prevent that from happening.
Got it. Great. Thanks. That helps because I just think about it and I'm like, I just say, here's a heat lamp, let us know how close it is, all this stuff. So, I mean, let us know if that feels too hot for you, but yeah, I've never gone over it after the consent form.
Yeah.
So it's good to know. Thank you.
Okay, and we have another one. So thanks for that, Christy. Lauren has a question. So Lauren, I'm gonna permit you to come on and share with us.
Hi, thank you so much for taking my question. Okay, so I was actually covered with MIEC, and I had a boss who was as well. I worked in his clinic, and I was just always pondering the situation over the years. This happened a couple years ago, didn't turn into a claim that I know of, but the patient came in for hypertension, and I think her goal was to reduce her blood pressure medication. I remember when I saw her, she'd been seen across like several different practitioners in the clinic. And I remember when I saw her, I told her, that wasn't within my scope of practice and to make sure she's doing it under the guidance of a doctor or physician. And she said she was having it done under the guidance of her pharmacist. But she was very type A. And I suspect that she actually wasn't, if that makes sense. And so I remember like we were treating her over the course of, I don't even think it was a couple weeks. I think it was more like 11 days. And she ended up having a hypertensive crisis. Where she ended up in the ER because she was reducing her blood pressure medications quickly. And I just remember thinking it was kind of suspicious at the time how aggressive it seemed that she was reducing her doses. So I remember documenting in her chart, like, that we had told her to do it under the guidance of a physician, that she had said she was doing it under the guidance of her pharmacist. So I remember coming into the clinic one morning and I came into an email where she was saying that she went to the ER over the weekend and she had really high blood pressure and the acupuncture had stopped working, quote unquote. And basically, I had encouraged her to follow her doctor's directives, definitely understand, this kind of thing, because my boss wasn't around. So it was something that, I remember I just kind of, I responded nicely and in a caring way, but also like, yes, definitely follow your doctor's directives and that's understandable, etc. But I, over the years, have gone back to that situation in my mind and always wondered like what type of liability would an acupuncturist have in this situation. Is documenting in the chart that you had told her and she had said she was having it done under the guidance of her pharmacist or her physician, would that have been enough? And how would that work in a situation with a clinic where you have multiple practitioners seeing this patient who ends up in this type of situation from a pre-existing condition? So I hope you don't mind my question, but I've always just wondered.
Yeah, no, that's a really good question. And it sounds like you handled it really well and the way that is appropriate. And so the patient asked about this, you charted that she was asking this, you charted what your response was, if you were consistent, if she brought it up multiple different times. So as long as you're not telling her what she should be doing, right, as far as changing her medications, et cetera, and you're keeping it to the treatments that you're doing and you've charted that, then you've closed the door, right? Or you've ensured, I should say, you've ensured the steps that you need to take to protect yourself. If you're working in an environment where there's other practitioners, then if that's, you could mention that to the other practitioners. I don't know how you guys have it set up, whether you have roundtables or group discussions or things like that, but that's something you might want to mention to the other practitioners and ask them, some of this is just because your gut was telling you that kind of stood out to you, right? So you can follow up with the other practitioners. What are they doing as well? Now, if they're not documenting it, like that's not your responsibility for how they document it. You're responsible for how you're documenting it. But I do think that that's a good idea to discuss with the other practitioners that are in that office. And then if the patient emails you and says these things, take a copy of those emails and put it into the chart.
Okay, great. No, I really appreciate that. So basically, our liability ends in terms of accurate documentation and saying that you had told her it wasn't in your scope and that she was doing under guidance of risk. Okay, because I was curious, like if she would want to later, come back and be like, oh, well, I had this ER visit and someone needed to pay for these expenses. You know what I mean? Like that's just what happened according to my knowledge. But I was always wondering if it had gone further south.
Well, and it could, right?
Yeah,
Like even if
yeah.
you do everything right, she could still, blame you or file a claim because she felt like she was harmed. Remember, they can sue for any reason. And so if they go to a lawyer and the lawyer says, great, you had care from this person, this person, this person, this person, this person, they can sue everybody, right? That's usually what plaintiff attorneys will do, is they will collect everybody that could possibly be involved. And then that's when your malpractice carrier would respond. They would read your notes. She would talk, give them information about what happened. They would do more discovery. And if you can prove, no, I documented, I told her no, etc., and it shows that you were not involved, then that part will get dismissed. It's kind of like the plaintiff's attorneys will come in and go, how many people can be on the hook for this, right? And as they go through all of it and they find out, oh, no, that doesn't have culpability, that one doesn't have culpability, that one doesn't have culpability, then they see who's left at the end.
Thank you. I appreciate that.
Sure.
All right. Thank you, Lauren. So many great questions and audience participation tonight. Thank you. It really brings the material to life to hear these real world examples that everyone has shared. Anne Marie, any last closing thoughts? One thought I did want to mention, I put it in the chat because I think I'm correct that you said these slides would be available on the MIEC site at some point, and we'll also make the recording available to everyone. Is that true about the slides, or am I?
Yes, they should be on the, hold on. If you want, I could put that page back up that has the URL. Would that be helpful?
Sure,
We
yeah.
can put it in the chat.
Yeah, you can type it into the chat or
Okay.
tell me and I'll type it in the chat for everybody.
All right, let's see.
And then the recording will be available tonight. We'll send out that link in a post-event email. Do look to your registration link to figure out how to take your CEUs. One lucky attendee tonight will win a $100 gift card, like a Visa gift card, as a gift from MIEC, who was our corporate sponsor tonight, to bring this material here. And yeah, and I just thank everyone for joining. We will be back here on December 2nd, I think it was. I'm just going to look at my calendar to make sure I'm right. December 2nd, we'll have Dr. Jenny Nieders talking about dry needling, myofascial pain, going to be a really cool clinical night. And then 2 weeks after that, on the 16th of December, Dr. Julie Tran, CSOMA's president, and I will be presenting a town hall on our legislative update, year in review, what we're looking forward to in 2026, dry needling talk, whatever else needs to happen, we will be talking about that then. And then join us. Just put it in your schedule the first Tuesday night of every month. We are getting together. Be here for free if you just want to hang out. Pay a little money if you need the CEU credit. It goes to a good cause. It keeps CSOMA going, and keeps us going to lobby days and other things like that, advocating for the profession. If you're not a member of CSOMA, please consider it. We're a bit like NPR, right? Everyone can enjoy, but not everyone is contributing. And that's okay. But if we all do our part with either volunteering some time, we do have openings on our board. If someone's interested in putting on some events, especially if you like education and events, we could use some more support in 2026. And consider joining the board or consider just joining CSOMA. It's great that you came out tonight, but we do need people to join to help protect our profession. So there's membership rates for, hopefully everyone can afford to join somewhere in there. If you can't afford what's there, but you do want to join, reach out to me at raw@csomaonline.org and let's figure out what we can make happen. Anne-Marie Trioni, thank you again for bringing us such important information, how we protect ourselves, our practices, and ultimately our patients too, by understanding defensibility and claims and how to not be scared when things go wrong. They call it a practice for a reason and mistakes happen, right?
No, that's true. Well, thank you for inviting me. And I will say that if anyone in the audience, if you want more of this, right? If you want us to talk about other issues like professional boundaries, et cetera, let's let them know, because I'm happy to get this information out there. Being an acupuncturist myself, I feel very attuned to my fellow colleagues, and I am in a position where I can provide, I'm not treating anymore, I'm not in clinic anymore. So instead of helping my patients, I get to help you. And it really is a passion of mine to be of service to other people. And so whatever I can do to support you and help your practices and help your patients, please, please let them know, and I'll be happy to address them.
Thank you so much, Anne-Marie. Okay, so I'm going to just stay on here for the chat, but everyone, that wraps it up for tonight. Thanks for being here. We'll see you on December 2nd. Join us again. Have a great holiday season, everybody. Hope you got out the vote today. And thanks for being part of the CSOMA community.
Thank you. Bye.
Well, I think your chat message is only going to hosts and panelists
Ah,
for the
thank
side for the
yeah,
side the link to the slides by Anne Marie
yeah.
because
So
we're on
anyway,
yeah, we're gonna have to
yeah, I
email
didn't
it to
think it was
everyone.
for everyone. Yeah, who was asking about it? Jordan, are you still here? The slide link was, yeah, Jordan is here. The slide link, Jordan, if you're still here, was up above. Anne-Marie posted it. It is.
Yeah, but what I'm saying is when you put it in the chat, it's only going to hosts and panelists. He's not seeing it.
Oh, Anne-Marie didn't see it. Okay, mrac.com so it wasn't just my text. Presentation.resources /
No, everyone can see it because now
Yeah.
yours
Did I get it
originally it was just a
right?
host and panelists. That's why
Yeah,
it
yeah,
was
when Anne-Marie put it in. Yeah, thanks, Josh, for
yes.
loading us to that. So www.miec.com / presentation, just making sure I got it right. -resources / I think that's it. The link no. Okay, hold on, Josh. Hang in there. I'm gonna try and take the link and cut and copy it freshly.
Well, that's because you misspelled resources.
It figures I had to make a spelling error in front of it. All right, here I got it. Try this one.
It's 9:30, y'all. Give us some grace.
These are my thinner glasses too. I think we got it. Yay, Lauren says it's working. Okay, yay. All right, any other questions for the last 8 folks here? Thanks for being here tonight, everybody. I'm gonna hang up and go have a cup of tea. Yeah. All right. Thanks. Thanks, Julie. Thanks, everybody. I'm gonna
Have
end
a good night.
it.
Bye.
Bye.